with your wire. What would be, before we go to the technique, what kind of support guiding catheter and size that you use?
Yeah, Alex, this is an important question. Yeah, I think it is case like that. We are think about double stent technique. I use the 7 French, and my first choice of left coronary artery PCI, it's EBU or VODA. Now we are using here EBU 3.5 7 French.
And another question is that for your technique for pre-dilatation and bifurcation. So when you're going to do provision, I saw that very clearly that you did more aggressive preparation, and I would totally agree with you. You pre-dilate the side branch, the main branch, perhaps with a little bit of a size balloon for pre-dilatation. But when you do provision, and I want to see Bahar comments on that.
Yeah, while they are working, I would like to ask you or the panel, do you think that ultrasound in this situation plays any role? For example, to see whether there's really calcification involved in this bifurcation? Do you have aggressive preconditioning of the bifurcation? Thinking maybe of a cutting balloon if you have calcifications. It's a long lesion in the LAD. It's a fairly long also in the diagonal. So I think lesion preparation, like what he did, is very important in this case. My question to Expedito or to you, do you think that when you have a lesion like that ultrasound plays any role in improving the outcome?
I think this is a great question. Fumi, I would like to take on this one. For IVUS guided treatment for bifurcation, pre, post, both, what do you think?
Yes, especially in this kind of the true bifurcation region, we must check the plaque distribution at the carina to expect the plaque shift for the side branch. And after, of course, pre-dilatation, we can know how much dissection happened where. So, and usually in Japanese way, we use IVUS pre, post, and the final.
In Chinese way as well?
Yes, I think IVUS is very helpful in this situation, in this true bifurcation. But even in my hospital, my cath lab, people will do differently. Different people do different strategy. For this particular case, just asking your question, answer your question. If we do, maybe we do 6 French transradial. 90% of the cases by radial approach.
Yeah, I think in the U.S. that even in centers that don't do a lot of IVUS, true bifurcations like this really do have a role to play in terms of both morphologic assessment and choice of therapies. It may be that cutting balloon might have been a better preconditioning technique, and the one way that you might save yourself from having that second stent would be if you could prepare that diagonal sufficiently.
In other words, there are 2 osteo, right?
Yeah, exactly. And it needs to be pre and post, definitely.
Miguel.
I think it's important in my practice to use 7 French guide catheters for two stents or 2 balloons. It's more safe. It's very annoying when you stay trapped within a guiding catheter. With 2 stents you cannot maneuver. And we have used 7 French even through radial access without no greater difficulty.
Great.
In the majority of patients you can use 7 French through radial.
So Expedito, now you're in a crucial time there. You have 2 long stents, so tell us what you're going to do now.
First of all, thank you for the comments, the suggestion. Thank you, Eberhard. I think IVUS here, it could be a good option. We have planned to perform IVUS after. We use Inspire 30, 38 in LAD and Inspire 2.5, 28 in the diagonal. Then you see the both stents was very the crossability, the navigability was very nice. Then we have the stent of in LAD a little bit higher, and you have just a little mini crush in diagonal. I fully agree with Miguel. It's not a big vessel proximal. Then I'd like to avoid too many stents in the proximal LAD. What do you think about, Alex, the panel, about the position of the two stents in the LAD in diagonal?
It looks good from here.
I think.
So the steps are first to inflate the side branch, right? Yeah. And then you have the main branch already in place. So immediately after that, you inflate, and then you're going to do some crush. And I have to say that this is really mini crush. I don't see many struts or long.
But it's interesting that that most people in this situation use mini crush, even though there's not a good proof for it. You can also use culotte in this situation. People kind of at least tend to go away a little bit from it because it's a little bit more complex, probably. Yeah. And this is an easy way to get out of a problem. I think it's very well done.
So I think that the difficulty with trying to do the mini crush this way is you can miss the ostium of the branch with your stent, and I think that's where knowing where that's at by IVUS or other, looking at the proximal marker on that diagonal, you wonder how close it is.
Yeah, and I think Expedito, what you said, I mean, you don't have it here, but for us in Europe, it would be a perfect case for dedicated stent. I mean, perfect case. Long lesions, bifurcation, that would be really fabulous.
Thank you, Eberhard. I think it's if you freeze the image, you see the diagonal, you have just a little metal in the LED, just to be sure. It's the stent has covered the osteo of the diagonal. What do you think, Alex, in the panel? I think it's the position of the stent in diagonal. I think it looks like good.
Here looks good. It's difficult to say that 100% that is going to be
you can
perfect.
Probably push it a little bit out more, but this is good. I mean, it's crush.
A little bit more proximal.
Yeah, I might bring it a little more proximal. I don't know where that stent sits on that balloon, but.
I don't know about the patient. I'm starting to feel a little discomfort with these two stents.
I can hear.
Miguel was saying that he is a little bit nervous here because the two stents are there for a long time if the patient is experiencing any ischemia.
Yeah, but it's a good comment. We control completely the ACT. It's good. I think we are working very, very quiet, and the patients are doing very well. No pain. And we have a support of Pedro Horta here. So I'm completely quiet, comfort.
The point of doing perhaps a more aggressive pre-dilatation when you deal with bifurcation, because you need to take the time to be precise and to do the right deployment.
Can I make a comment on the positioning now? I would probably not leave it the way it is now. Mm-hmm. I'm sorry with my voice. I would push the diagonal a little bit more in, because now you have fairly close four layers of stents, and if you rewire it, you might actually encounter a little problem, and you don't really need it. You covered the ostium very well. So at least from this perspective, I would probably push the diagonal stent a little bit more in, so we have a little separation.
Yeah. Did you get that, Spedito?
Yeah.
My voice.
I'm going to push a little the LED and the diagonal too.
Because you have the two.
Yeah, perhaps more the diagonal. I think the LED was in a good position.
Diagonal. The LED was good.
Yeah, I think the diagonal now is good, isn't it?
Yes. Maybe it's still a little too heavy. You go a little farther.
1 millimeter.
Yeah, see, you have many layers now when you rewire.
That's always one of the difficulties here, is deciding where you're at. You've got the heart that's moving and trying to position both of those.
And the distinction between crush and mini crush really is...
Yeah, it's a matter of millimeters, 1 or 2 millimeters.
Two openings.
Inflated 12 at the diagonal.
Okay, here we go.
Atmosphere in diagonal.
So he decided.
He's doing the case.
Of course.
Okay,
You deployed the first one in the diagonal. Now, yes, the LAD was.
Yeah, that's a very important step now, to pull the balloon back. If you keep the balloon in,
Oh my gosh,
you have a
it's going to
problem.
be trapped. And also, you know, the angulation here is not so easy to evaluate. Why did you take the wire out?
Yeah, that's an interesting question. How many?
I'm nervous.
You're nervous to leave the wire?
To have, yeah.
I generally leave the wire there.
Yeah, I do too.
Yeah, I as well. Although it's interesting that there are a number of people who don't.
Now we're going to deploy the LAD.
See, the reason why I keep the wire in is you have an orientation where the ostium is, and then you use the flip-flop of the two wires.
Yeah, I think it's a little bit easier to rewire.
Yeah. Well, we'll see.
Hey.
How many atmospheres?
LAD as well.
How many atmospheres?
12.
12, 12.
12.
So now he crushed the diagonal against, he crushed the diagonal against the LED.
Okay. And now I have to say that at this point, kissing is a must.
Kissing is always a must.
Mainly after, right?
No, I mean bifurcations.
Let's take a picture now.
See, he pinched a little bit. Now you need it.
Yeah.
Yeah.
You know, after crush, we have to do a
No matter
balloon.
what it looks by angiography, that you have to do it anyway.
So he's rewiring it now and then use two balloons, right? And this is where I completely agree with Miguel. I think in bifurcations, it doesn't make any sense.